Welcome, dear colleagues and friends. I'm Professor Konstantinos Triantafyllou from Athens, Greece, and I welcome you to this EAG Wednesday webinar, where we have two exceptional panelists, Dr. Roos Pouw and Professor Bas Weusten, both coming from Netherlands, to discuss issues on the management of Barrett's esophagus. So welcome Bas, welcome Roos. Thank you for accepting the invitation to participate in this webinar. Dear colleagues, as you already know, this is the fourth consecutive year where ESGE offers you the opportunity to view high quality presentation on the hottest endoscopy topics. And this presentation comes from world leaders in endoscopy. So you also have the time and the opportunity to interact with the speakers and to participate by submitting online questions. So please focus on the bottom of your screen when there is a Q&A tool where you can write the questions, and these questions will be posed to the presenters during the discussion or during the presentation. And of course, dear friends, this is a free, this comes from the EAG, webinars come for free. And now it's time to formally introduce our speakers, well known, both with significant contribution in the literature and in clinical practice regarding Barrett's esophagus management. And great pleasure to introduce again, it's the third time during our sessions of webinar, Bas Weusten. Thank you, Bas, and you have the floor to start the presentation.
Dear ladies and gentlemen, it's my pleasure to deliver this webinar together with Roos Pouw on the management of Barrett's esophagus. And we entitled this webinar Barrett's Esophagus Anno 2021, ESGE Position Statement and Beyond. These are my potential conflicts of interests. The objective of this webinar is to refresh your knowledge on the 2017 ESGE position statement on the endoscopic management of Barrett's esophagus. But in addition, we wish to to discuss with you three topics in which there are new insights and which are, I think, very interesting to discuss. And the first one is the treatment of T1b, so submucosal Barrett's cancer. In addition to that, we will discuss the issue of low-grade dysplasia. Ablate or not ablate, that's the question. And in the end, I will show you some new and exciting ablation techniques. Having said that, I will start off with a case. So this is a 56-year-old male patient who had an endoscopy for persisting heartburn. And you see this on your endoscopy. And you see there is a small, well, how do you call it, the tongue of cylindrical epithelium here. And the question here is, what do you consider is most appropriate for this patient when you do the endoscopy? Do you take 4 quadrant biopsies, including 1 biopsy of the tongue? Would you only biopsy that small tongue, or would you perform no biopsies at all? And I would kindly ask you to answer this first question. Well, that's quite interesting. It's almost well, very precisely split in 3 groups. 4 quadrant biopsies, including the tongue, a targeted biopsy of the tongue only, and no biopsies at all. Well, let's discuss what the ESGE guideline here advises you to do. Well, the position statement wished to contribute to a more cost-effective approach to the care of patients with Barrett's esophagus through, on the one hand, reduction of the number of surveillance endoscopies for patients with a low risk of malignant transformation, and on the other hand, to centralize the care for those with a higher progression rate. And we know that those very small tongues of columnar-lined epithelium really carry a very low progression rate. So that led to the stratification of the intervals for Barrett's esophagus surveillance endoscopies according to the length of the Barrett's. And the position statement is that when you have a very small tongue like this, a very small tongue of cylindrical epithelium, you should not take biopsies and you should not survey. So the third answer was the correct answer. So no biopsies at all. If there's a Barrett's length between 1 and 3 centimeters, you should survey those patients at the 5 years interval. And if there's a considerably longer Barrett's up to 10 centimeters, the interval is reduced to once every 3 years. And if the Barrett's is longer than 10 centimeters, well, then the ESGE advises to refer those patients to a Barrett expert center, because those are the patients with a high rate of progression to high-grade dysplasia or even cancer. The ESGE also defined stopping criteria. So if a patient has reached the age of 75 at the time of the last surveillance endoscopy with no previous evidence of dysplasia, it is advised to stop the surveillance, because the likelihood that that patient will at the end die from esophageal cancer is quite low and probably not worthwhile surveying. So a second case, this is a 74-year-old female patient referred for a visible lesion, as you can clearly see here at the 1 o'clock position. And you can also see it in the retroflex position, so at the G junction here. And biopsies, referral biopsies showed adenocarcinoma. And I decided to perform an ESD on this quite bulky lesion, and you can see the results here. And the pathology showed a T1 SM1, meaning submucosal invading, but only at the extent of less than 500 microns into the submucosa. G2, so moderately well differentiated, no lymphovascular invasion, and a negative resection margin, so a radical endoscopic resection. So the next question to you is, what is the most appropriate step here for this patient with a submucosally invading tumor with characteristics like these? And the options here are chemoradiotherapy, esophageal, an esophagectomy with a gastric pull-up, or further endoscopic management. And I again invite you to vote. So you can choose either chemoradiotherapy, an esophagectomy with a gastric pull-up, or endoscopic management. So let's see if we can get the results. Well, this is quite nice. Most of you, I see that most of you here say that endoscopic management is the most appropriate step here. And I fully agree. About 15% choose chemoradiotherapy or an esophagectomy. And there is good guidance here by the ESGE position statement. The statement here is that endoscopic resection is the first choice therapy for mucosal cancer. So this was a submucosally invading cancer, but for mucosal cancer, endoscopic resection is the first choice therapy. And it is formulated as such that in patients with T1b esophageal adenocarcinoma, so invading into the submucosa, endoscopic therapy is recommended if the submucosal invasion is limited to 500 microns or less, and if the tumor does not show poor differentiation, so if it's a well or moderately well differentiated tumor, and if there's no evidence of lymphovascular invasion, and if the deep resection margins are free. So then endoscopic management is recommended. So let's continue here with well, something beyond the guideline, new insights in the treatment of T1b Barrett's cancer, and I will now handle the floor or the microphone to Roos Pouw, and I invite her to well, to continue from here and share with you some new insights in this patient category. Roos.
Yes, thank you, Kostas, and thank you, Bas, for the introduction and the invitation, of course, to be part of the webinar this evening. I'm very happy to be here, especially since I can tell you something about a very interesting topic, I think, which are the new insights in the treatment of T1b Barrett's cancer. So endoscopically, we can treat patients, but of course we cannot treat the lymph nodes. So the decision to treat a patient endoscopically heavily is based on the risk of the patient to develop lymph node metastases. And as Bas has already told you, the risk of lymph node metastasis in mucosal cancer is very low. It's less than 1%, so this is an accepted indication for endoscopic treatment. When we look at the patients with submucosal cancer, however, the risk of literature that's mentioned, of lymph node metastasis that's mentioned in the literature is still very high and ranges from 0 to 46%. So generally, the guidelines still advise to refer patients with a submucosal cancer to the surgeon. As was already discussed and which is included in the ESGE position statement, is that we have learned that patients with a low-risk T1b cancer also have a relatively low risk of lymph node metastasis, less than 2%. And this is defined as a superficial submucosal cancer with well to moderate differentiation, no lymphovascular invasion, and of course, the tumor needs to be resected radically. So this is an accepted treatment as well. But again, the high-risk cancers are still advised to have surgery. So these are the tumors invading beyond 500 microns into the submucosa with a poor differentiation grade or undifferentiated characteristics, with lymphovascular invasion, or if the tumor could not be resected radically. So we get to a next question. So this is again a patient who had an ESD for Barrett's cancer, and the histology in this case showed an SM2 cancer with poor differentiation. There was no lymphovascular invasion, but the resection was radical. In these cases, we also always do a CT scan and an EOS, and there were no signs of distant metastasis or lymph node metastasis. So would you refer this patient for surgery, or the second answer is then, of course, would you keep the patient under endoscopic follow-up? So I'm very curious to see what you're voting here. Yeah, so I think that the question that was asked before was a low-risk cancer, and the majority of you voted that you could keep the patient under further endoscopic follow-up. And in this case, it's a little bit 50-50. So this is a high-risk submucosal cancer, and half of you would refer the patient for surgery, and the other half would follow the patient endoscopically. So currently, the treatment algorithm for patients with Barrett's cancer is as follows. If we see a visible lesion, we resect it. So we have a nice tissue specimen that the pathologist can assess, and the pathologist can then tell us if it's a mucosal cancer that is radically resected or if it's a submucosal cancer. If it's a mucosal cancer, the patient is further managed endoscopically. If it's submucosal, we want to know a little bit more about the other risk factors. If it's a low-risk cancer, the patient, again, can be treated endoscopically, but if it's a high-risk cancer, we still advise surgery for most patients, at least the guidelines do. But we have some very interesting new insights. So a couple of years ago, also the low-risk T1b cancers were advised to undergo surgery. But as was already mentioned, given the low risk of lymph node metastasis in these patients, by now we have also already accepted endoscopic treatment for these patients. And what we've also learned the past years is that the risk of the lymph node metastasis in high-risk submucosal cancer patients appears to be more around 16 to 30% and not up to 46%. But still, for these patients, an esophagectomy with lymph node dissection is advised, even though endoscopic resection may have resulted in radical resection of the primary tumor. So this could mean that we still refer more than 70% of these high-risk patients to undergo unnecessary invasive surgery. So how do we explain this difference in lymph node metastasis rates for the high-risk submucosal cancers that is found in literature? So the historical data was mainly based on surgical series. So in this, the surgical specimens were cut in 5mm slices, and the exact assessment of the invasion depth had no clinical relevance because the esophagus was already removed. But this, of course, could result in missing the deepest depth of infiltration, and therefore underestimation of the true infiltration depth, and thus an overestimation of the associated lymph node metastasis rate. More recent literature is mainly based on endoscopic resection specimens, and these specimens are cut very thin in 2mm slices. And if there's submucosal invasion, additional slices are cut. So you end up with a much more accurate assessment of the invasion depth, histological risk factors for lymph node metastasis, and therefore a better associated lymph node metastasis rate, which appears to be lower than we knew from the surgical series. So based on these new insights, we started the PREFER study, which is a prospective international multicenter cohort study, in which we include patients that were endoscopically treated for T1b esophageal adenocarcinoma. And instead of referring these patients for surgery, we perform a watchful waiting strategy in which we follow the patients closely with 3-monthly gastroscopy and endosonography during the first 2 years, then every 6 months. They get a CT scan after a year. And we aim to include 141 patients in this study and follow them for 5 years. And we will look at the disease-specific survival and mortality and quality of life in these patients. So far, we have included 60 patients, and the median follow-up is now 14 months. There were 3 patients who developed a local recurrence in the esophagus that we could not retreat endoscopically. One of them was sent for direct surgery and turned out to have a T1b cancer, but no lymph node metastasis or distant metastasis. One patient had chemoradiation and is still waiting for surgery, and one patient refused additional treatment. And we found one patient who had a lymph node metastasis that was diagnosed with EUS-FNA 6 months after the initial endoscopic resection. This patient was also treated with chemoradiation and surgery, and no more tumor was found in the resection specimen. So although there were some events in this study, which of course we expected, the most important lesson so far is that we could still perform curative treatment in these patients, while we may have saved invasive surgery in a majority of these patients. So I hope in the future, based on the results of the study that is still ongoing, we may add an additional option for the high-risk T1b cancer patients, which is watchful waiting instead of immediate surgery, and then refer the patient for more invasive surgery or chemoradiation only if it's really necessary. I think then the moment is that I hand over the floor back to Bas.
Thanks, Roos. And maybe we can come back to this issue in the end of the presentation when we have some time for discussion. So I would move on here with the a third case, and in this case, it's a 60-year-old male with an endoscopy for a known Barrett's esophagus with a C3M4 Barrett's. And you can see the Barrett's here, and you can also see that I biopsied the Barrett's esophagus. And the biopsies came back by the local pathologist as low-grade dysplasia. So my question to you is, and I would like to ask you to use the voting system, what is the most appropriate here when your pathologist tells you that these biopsies show low-grade dysplasia? Would you repeat the endoscopy after 6 months? Would you send the biopsies for revision? Would you refer the patient to a Barrett's expert center, or would you straight on go for radiofrequency ablation? So maybe you can vote now. So either repeat endoscopy after 6 months, revise the biopsy, refer the patient to a Barrett's expert center, or perform RV. I think this is quite good. Most of you, 37%, voted for the revision of the biopsies. And I think that's actually the best option here. And another 34% voted for a repeat endoscopy after 6 months, and a minority for referral to a Barrett's expert center or perform RFA. Well, let's see what the position statement says on this topic. So the position statement says that when there's low-grade dysplasia in random biopsies, the best way to proceed is to let the biopsies get revised by an expert pathologist, and only after the expert revision decide what to do. And if the expert pathologist downgrades the biopsy as non-dysplastic, that patient should be followed up according to the regular surveillance interval. And only if the low-grade dysplasia is confirmed by the expert pathologist, then you should refer the patient to a Barrett expert center. And in the Barrett expert center, it can be decided what to do with this patient. And the statement now says that if the low-grade dysplasia is confirmed in a subsequent endoscopy, that ablation should be offered. But also on this topic, the low-grade dysplasia in Barrett's esophagus, there are some new insights. And so the question is, low-grade dysplasia, ablate or not ablate? That's the question. And for this, to get an answer on this, I again handle over the floor to Roos. So Roos, please take it away.
Yeah. So that's a very interesting question, to ablate or not ablate. And I think, I don't know about you, Bas, but that's a question I ask myself a lot when I do outpatient clinic and I see patients that are referred with low-grade dysplasia, because not every patient is the same, but also, as I will tell you, not every diagnosis of low-grade dysplasia is the same. So this is an interesting study in which 264 cases of low-grade dysplasia from community hospitals were reviewed by an expert panel with expert pathologists. And interestingly, they downstaged the majority of low-grade dysplasia diagnosis to non-dysplastic Barrett's. Some of the cases were downstage to indefinite for dysplasia, and only a minority of cases were confirmed to have indeed low-grade dysplasia by these expert pathologists. And what makes it very interesting is that after a follow-up of 39 months, we saw that in the patients that were downstage to non-dysplastic Barrett's or to indefinite for dysplasia, the risk of progressing to high-grade dysplasia or cancer was sort of comparable, 0.6 to 0.9% per patient per year, which we know from the Barrett surveillance studies. But for the cases where the low-grade dysplasia was confirmed, the risk of progressing to high-grade dysplasia or cancer was quite high, 9% per patient per year. So this indicates that expert pathology revision of low-grade dysplasia is important, because it's just a very difficult diagnosis for pathologists because the reactive changes, which you of course often see in Barrett's esophagus due to the reflux, may mimic dysplastic changes. So this is a difficult diagnosis and pathology revision can help. So then we get to question number 5. Which variable increases the risk of progression in patients with low-grade dysplasia? I have 3 possible answers. And I'm curious to see which one you think is most relevant. Is that confirmation by 2 pathologists, persistence of the low-grade dysplasia over time, or presence of multifocal low-grade dysplasia? You can choose the one you think is most important in predicting progression to high-grade dysplasia or cancer. Okay, so this is a very interesting result. So most of you think that multifocal low-grade dysplasia is the most important risk factor when looking at low-grade dysplasia for progression. But all 3 answers get some of your attention. So we'll go on with the presentation, and I think I can answer the question. So first, I will introduce a very interesting study from a colleague of mine from Amsterdam, in which 255 cases with low-grade dysplasia, all diagnosed as low-grade dysplasia by an expert pathologist within the Netherlands, were reviewed by 3 pathologists for the sake of this study. So 3 expert pathologists reviewed 255 cases with low-grade dysplasia made by other expert pathologists, and they reviewed the baseline low-grade dysplasia diagnosis as well as subsequent low-grade diagnosis during surveillance of these patients. In this whole group, 18% of patients progressed to high-grade dysplasia or cancer during a median follow-up of 42 months and a median of 4 endoscopies. The endpoint of the study was high-grade dysplasia or cancer development, but the study also looked at a number of predictor variables and which one was most relevant for reaching the endpoint. So they looked at the number of pathologists confirming the low-grade dysplasia diagnosis, multifocality of low-grade dysplasia, and persistence of low-grade dysplasia over time. And when we then look at the confirmation by more pathologists, this is, I think, a very nice graph. So of those 255 cases of low-grade dysplasia, and there were some cases in which these 3 pathologists did not confirm the diagnosis of low-grade dysplasia. Progression in these patients was low. If one of them confirmed the diagnosis of low-grade dysplasia, progression to high-grade or cancer increased. If 2 of them agreed, the numbers increased even more. And if all 3 of the pathologists confirmed on the diagnosis of low-grade dysplasia, the risk of progressing to high-grade dysplasia or cancer was highest. So the more pathologists confirmed the diagnosis, the higher the risk of malignant progression. And then the study also looked at persistence of low-grade dysplasia over time. Here you see the pathologist number 1, number 2, number 3, and their cumulative analysis. And then all the pathologists looked at if the low-grade dysplasia during the first follow-up was reproduced during the second follow-up, so the subsequent endoscopy. And in case of no, there was no subsequent low-grade dysplasia diagnosis. If it was yes, the second endoscopy also showed low-grade dysplasia. And if you then look at the outcomes, the odds ratio, so the chances of progressing to high-grade dysplasia or cancer significantly increased if low-grade dysplasia was found as a second endoscopy. So that's also a predictor for malignant progression in patients with low-grade dysplasia. And then the third variable, the multifocality of low-grade dysplasia, which was surprisingly in this study not found to be associated with progression. So not all cases of low-grade dysplasia were confirmed in this study, as you see here. So some of them were not confirmed to have low-grade dysplasia. Some cases had low-grade dysplasia only in 1 biopsy. This was at the baseline endoscopy. and others were found to have low-grade dysplasia in multiple biopsies. And when you then compare the risk of progressing to high-grade dysplasia or cancer, you see that there was not much difference in the patients who had low-grade dysplasia in one biopsy or in multiple biopsies. So according to this study, also if you have low-grade dysplasia in just one biopsy, the risk of progression can still be the same as in a patient who has multifocal low-grade dysplasia. So this appears to be less of a risk factor. But that the risk of malignant progression in patients with confirmed low-grade dysplasia is increased, I think is something we clearly know right now. And then why are we treating these patients? I think there are two interesting studies in this respect. The first one is the AIM dysplasia trial from 2009, in which patients with either low-grade dysplasia or high-grade dysplasia were randomized to ablation with radiofrequency ablation or sham treatment, so no ablation. And in this study then, they also looked at risk of progressing to high-grade dysplasia or cancer. And what you see is that the risk of progressing from low-grade to high-grade dysplasia was much higher in the patients who were not treated compared to the patients who were treated. And the same holds, of course, for high-grade dysplasia in this study. So RFA significantly reduced the risk of progression. Then in Amsterdam, we performed an international study in 9 European hospitals, which was the SURF study, in which we included patients with a Barrett's esophagus and at least one confirmed diagnosis of low-grade dysplasia. Patients were randomized to either endoscopic surveillance according to the guideline or radiofrequency ablation, and the study looked at progression to high-grade dysplasia or cancer. And after a follow-up of 36 months, there was one patient in the RFA group who developed a cancer, but 18 patients in the surveillance group who progressed to high-grade dysplasia or cancer. So this was quite a significant difference, which made the study to be stopped because of the superiority of RFA in preventing malignant progression. But something that's also interesting in this study is that 19 patients in the surveillance arm, so 28%, did not have their baseline low-grade dysplasia diagnosis reproduced during surveillance. So you could say that in this study, one diagnosis of low-grade dysplasia may result in overtreatment of almost 30% of your patients. We performed a follow-up study on the SURF study, in which we added 40 additional months of follow-up to the study, resulting in a complete follow-up of 73 months. Here on top, you see the results of the SURF study with the patients treated with RFA, and here the patients who were surveyed. And in our follow-up study, we looked at both groups, and we found that in the RFA study, no more patients progressed to high-grade dysplasia or cancer. So in this group, there was still only one patient who progressed. And in the surveillance group, after closure of the study, some patients could be treated with RFA, either because they choose to or because the doctor wanted to. So 15 patients were treated with RFA, and 9 discontinued follow-up. And in the rest, there were 4 patients who progressed to high-grade dysplasia and 1 patient who developed a cancer. So the overall results of the SURF study and the follow-up study were that in the RFA group, there was only 1 patient with a cancer compared to 23 patients in the surveillance group. But again, you have to be aware that 16 were high-grade dysplasia cases and 6 were a mucosal cancer. So these were all curatively treated endoscopically, and the 1 patient with a T1b cancer was at that time referred for surgery. So low-grade dysplasia, ablate or not ablate, I think it's always very important to realize that not all diagnoses of low-grade dysplasia carry the same risk of neoplastic progression. As I told you, there are some low-grade dysplasia diagnoses that are more risky than others. So if it's confirmed low-grade dysplasia, sometimes you have a panel of pathologists looking at the low-grade dysplasia. If more than if two or more of them agree on the diagnosis, the risk of progressing to high-grade cancer also increases. The same holds for persistent low-grade dysplasia during surveillance. I've also shown you that RFA really decreases the risk of progression in Barrett's patients with low-grade dysplasia. But still, I think that strict surveillance remains a legitimate alternative, and especially since the majority of neoplastic lesions found during follow-up were early lesions that could be curatively treated endoscopically. So I think for every patient referred with low-grade dysplasia, you really should balance the advantages of RFA treatment against the patient preference, comorbidity, and life expectancy. And then still, I think it's always a very difficult decision. And then I'm happy to hand the word back to Bas.
Thank you, Roos. I think you nicely discussed the two intriguing developments in the field of Barrett's. On the one hand, we are getting more and more aggressive in treating T1b cancers endoscopically instead of referring all patients with T1b to the surgeon. And on the other hand, we are more and more conservative, so to speak, in what patients we ablate. At least that's what I notice in my own practice, that I'm more reluctant to ablate everyone with low-grade dysplasia. What I did when the SURF trial just appeared in the literature. Having said that, the next part of the presentation will be on new endoscopic ablation techniques, just to share with you some exciting developments here. Let's see. Well, of course, RFA is the gold standard here. It is very well studied. We know and have good data on the efficacy. It is effective and it's relatively safe. I will show you a little bit on APC and especially on hybrid APC. That's a new technique or more or less new technology, and there are some new data on that treatment. And I will also show you some slides on cryoablation, especially on cryoballoon ablation. So what is hybrid APC? Well, APC, of course, is a well-known technology, but hybrid APC is a combination within one catheter where you can combine the application of APC with the creation of a submucosal cushing by submucosal injection of saline or other fluids. And that is done by a rather stiff catheter, and through the catheter you can, under high pressure, flush water, and the force of the jet of water which exits the tip of the catheter is such that it easily penetrates the mucosa, and so you can perform a submucosal injection and create a submucosal cushing without exchanging your devices and without using a needle. And the video will show you an example. This is a very short Barrett, of course, and you see that by pushing the catheter against the Barrett's mucosa and hitting the pedal, you can see there is some submucosal fluid injected. You can see the cushing here. And once you've created that cushion, you can apply APC, and you can do it quite quite aggressively, because that submucosal saline prevents the deeper layers from getting damaged. And so the submucosal injection, and you can repeat it on and on, that's quite easy because you don't have to exchange your accessory. So by doing that, you can possibly prevent stricture formation because you you safeguard the deeper layers by the submucosal cushing. And due to the fact that you are able to apply higher energies because of that submucosal injection, the risk of buried Barrett glands is less than if you just perform APC without submucosal injection. And these are very new data from a study led by Thomas Rush, which is now submitted. So these are really new data. He evaluated in a multi-center study across a couple of countries, 148 evaluable patients. Those are the regular real-life Barrett patients, and the majority needed an endoscopic resection because of a visible lesion. And all patients were treated with subsequent procedures with hybrid APC. And the median number of procedures were 2.7. That is more or less comparable to what we know, what is the median number of procedures if you apply radiofrequency ablation. And what is also nice to see is that the efficacy is quite high and also comparable to what we know from the RFA data, with a complete eradication of dysplasia of 98% and a complete eradication of 89% of all intestinal metaplasia. So also histological disappearance of all Barrett's epithelium. So that's quite good. And as I said, comparable to what we know from RFA. What surprised me a little bit, but what I think is a very good thing, is that the risk of strictures here is relatively low, 3.9%. And we know from the studies in treated with radiofrequency ablation combined with endoscopic resection, such as in this study, that the stricture rate after RFA in the whole all treatment sessions is about 9 to 11%. So that's not bad, I would say. The downside here is that it requires more technical skills, I would say, and it is also more labor intensive. But well, that's one of the developments I would like to share with you. And the other one is the cryoballoon ablation. And cryoablation, of course, is around for well, quite a lot of years now, but it is has always been based on a cryospray catheter. And this is a relatively new technology using a balloon. So you see the system with a handheld controller with a cap, and in the cap there is a cartridge containing nitrous oxide, a foot switch, and a balloon. And this is a schematic representation of the balloon. So you there is nitrous oxide which runs through the catheter and is contained within the balloon and gives an ablation patch with a temperature of minus 85 degrees of Celsius. And as the gas, the nitrous oxide gas, is retained into the balloon, it is vented back through another channel within the same catheter and is vented back into the handle and finally into the room. And that prevents overinflation, which was one of the risks of the cryospray. And it also gives a more predictable ablation, because if you ablate for 8 seconds, it is always 8 seconds and more predictable than when you have to handle a spray catheter. So this is the focal balloon. There's also a larger area balloon, and it works more or less similar, of course, with liquid nitrous oxide, which runs through the catheter. But now it's not a side hole, not a round side hole, but a fan-like, fan-shaped well, spraying of the liquid nitrous oxide. And while doing that, the catheter pulls automatically back within the balloon, so the balloon stays in place, and you, so to speak, apply a swipe of an ablation here. And here it's about 90 degrees, but the device is of 180 degrees, so half of the circumference. And again, the gas is vented back to the handheld system and back into the room. And these are examples. At the left-hand side, you see the focal catheter. So you look through the balloon is inflated, you look through the balloon with the catheter here within the balloon, and you see the freezing effect here. And here you see the 180 catheter, and you see there's a spray of slightly more than 100 degrees of Celsius, and there's an automatical pullback of the dispenser. And after you have applied this application of cryo ablation, you can rotate without deflating the balloon. You can rotate the catheter within the balloon and ablate the other half of the circumference. With the focal balloon, you can also apply side-by-side ablations, as you see here, and by that it's just similar to what you do with a focal Barrett's catheter, Barrett's catheter, so a radiofrequency catheter. So the balloon stays inflated. You see the ice patch here. You can rotate by using the pedal the inner shaft, and then you can apply a second ablation. And after you have applied the second ablation, you can again rotate the inner dispenser and go completely 160 degrees or 360-degree round. And also you can move up and backwards, so to more proximal location or more distal location, while keeping the balloon inflated. There's a study from Mimi Kanto. She has treated 41 patients in a multi-center setting, 22 without any previous ablation and 19 patients with previous RFA, with some low grades, some high grades, and 5 early cancers, with an EMR in a significantly lower percentage compared to the Thomas Rush study on hybrid APC. Again, a median number of 3 procedures to get rid of all the Barretts, with again comparable data on the efficacy in terms of complete eradication of dysplasia, 95%, and complete eradication of intestinal metaplasia, 88%. She also did a sub-analysis on the efficacy. All patients either treatment naive or refractory, and there was no significant difference between those groups. Stricture rate comparable to what we know from RFA. We have evaluated in a non-randomized fashion cryoablation versus RFA in patients with similar length and histopathological types of Barrett's esophagus. And we especially focused on the side effects being pain after the procedure. The efficacy was similar. And what we noticed is that the pain scores were significantly lower after cryoablation compared to RFA. And these are a diary. All patients filled out a diary with the days up to 14 days after the ablation and the pain score on the y-axis. And you see there's a difference in reported pain between cryo and RFA. Likewise, the duration of pain was significantly shorter after cryoballoon ablation as compared to RFA, and also the use of painkillers was significantly different in favor of cryoablation. So this is just to give you some some glance of what new technologies look like, and of course these technologies have to be studied much more extensively than it has been done now, also to see what the real advantages of those new technologies are. Well, ladies and gentlemen, to summarize what we have discussed this evening, we formulated a couple of take-home messages. So, following the ESGE position statement on Barrett's esophagus, it says that if the Barrett's length is less than 1 centimeter, please don't biopsy and don't follow up these patients. Of course, you should have a careful inspection, but that is, of course, for granted. The Barrett surveillance intervals depend on the length of the Barretts I showed you. And the other take-home message is, please don't survey patients who are more likely to die from other causes than from Barrett's cancers, especially non-dysplastic Barrett's in patients with a high age. Please dare to stop surveillance. Finally, if you get the pathology results by your local pathologist, and the urological pathologist tells you that it is either indefinite low-grade or high-grade dysplasia, please send the biopsies for revision. It's more cost-effective to send the biopsies for revision than to transfer the patient, because if the revision of the biopsies are such that it is downgraded to no dysplastic Barrett's esophagus, well, then we know that that predicts a low risk of progression. What I didn't show you, but what I would like to include in this take-home message, that these are the criteria for referral of a patient to a Barrett expert center. That is, patients with exceptionally long Barrett's esophagus, longer than 10 centimeters, because we know that the progression rate there is substantial. Patients with confirmed low-grade dysplasia by an expert pathologist, confirmed high-grade dysplasia, and of course, patients with early Barrett's cancer. So the new insights is that this decision to ablate patients with Barrett's esophagus with confirmed low-grade dysplasia should be individualized. And what I already mentioned, I noticed from my practice that I'm more and more moving towards a little bit more conservative approach here, not ablating everybody, but be more selective in who to ablate and who not to ablate. In low-risk T1b cancers, endoscopic management is the standard of care. That was already in the position statement, but there are again data confirming this. But also in high-risk T1b cancers, so deeper submucosally invasive or other risk factors such as poor differentiation grade or even lymphovascular invasion, endoscopic management really appears to be a valid alternative to surgery. And finally, new ablation techniques are emerging, but their role really needs to be determined. So with this, I think we have come to the end of the presentations during this webinar, and I am happy to handle back the microphone to Kostas. Please, Kostas.
Thank you, Bas. Thank you, Professor Weusten. Thank you, Dr. Roos, for your contribution today. You started very nicely for the fundamentals, I mean, the position statement and the guideline of the Eage regarding the management of Barrett's esophagus, and you tackled some very interesting and very difficult scenarios like the T1b area, adenocarcinoma, the management of dysplasia, and of course, the ablation. I'm happy to say that we have some time for discussion, and we have brief questions and expect very brief answer. To both of you, so you biopsy a lesion and you find out this is an early cancer. Before resecting this early cancer, do you need any other staging modality? In other words, is there any early role for advanced imaging or endoscopic ultrasound?
So I can answer that question. What we do is that we perform endoscopic assessment of the lesion. And if we think it's amenable for endoscopic resection, so if it's a Paris type 2 lesion and some of the type 1 lesions, we do not generally do a CT scan or EUS, but just do a diagnostic endoscopic resection, because then you get the result from the pathologist and they can tell you exactly how deep the tumor is invading. And we know that with EUS, sometimes also the early lesions can be overstaged as T2. There are some studies showing that if you resect these lesions that were staged with EUS as T2, then sometimes they are a T1 cancer. So we have more and more experience in doing just a diagnostic endoscopic resections and moved away from standard CT and EUS in all patients before we do endoscopic treatment. Sometimes we do if it's a very bulky lesion. But you can always do it after you've done the diagnostic resection.
The only exception is, I think, in lesions where you are in doubt whether it's amenable for endoscopic resection. Then sometimes you are searching for arguments not to do an endoscopic resection. And also if it's a quite risky ESD, for instance, then it can be worthwhile to do an EUS, not for the staging of the tumor, but for detecting lymph nodes. If you then see a malignant lymph node, then you can simply not do an endoscopic resection. But for those who we consider to be relatively low risk, there's, I think, no role at all for endoscopic ultrasound or CT scanning. And for the advanced imaging techniques, that's what was the part, another part of the question. I think advanced imaging is as good as the eye of the endoscopist. So it is more worthwhile to send a patient to a person who really has experience in looking at Barrett's lesions than to use any type of advanced imaging techniques.
Okay, thank you, Bas. And now against to Roos. You nicely saw the early results of your study regarding the management of T1b stage adenocarcinoma patients. Can you, from these data, or can you predict which would be the characteristics of patients or of the histology or of the tumor that may allow you to go with them with a watchful waiting option, or is it too early?
Yeah, so it's a very interesting question because, of course, some patients will have a higher risk than others, and of course, we would like to predict that beforehand. But the problem is that so far we have little events. So in the end, once we have the 141 patients, maybe we will have enough events to do some kind of prediction. But for now, it's so you would say that a deep invading tumor with lymphovascular invasion and poor differentiation would have a higher risk than just a deep invading, well-differentiated cancer. But we don't have the data yet. And there have been some retrospective studies, but they have some limitations. So unfortunately, we cannot predict yet which patients are better suited and which ones we might have to send to surgery right away.
So thank you for the direct answer. Bas, how do you decide to go with an EMR versus or an ESD for the treatment of an early
yes,
carcinoma?
Also a very good question. Conceptually, it's of course more appealing to do an en bloc resection. But we know from many studies that if you select the case as well, that a piecemeal resection followed by RFA leads to a very high efficacy, and that is safer and quicker and easier. But there are indications for ESD, and the one indication is the lesion I showed you during the presentation, and that it's a bulky lesion because that simply does not fit into your cap. And so it is impossible to do a resection with the cap on that lesion. So a bulky lesion, if it's amenable for endoscopic resection, is a case for ESD. The other one is a case in which you really anticipate deep submucosal invasion, especially the slightly depressed lesions, where the benefits of an en bloc resection are much more prominent than of a type 2A lesion. So in those cases, so in the cases in which I expect a deep submucosal invasion, I do an ESD. And of course, also in patients in a recurrence after previous EMR where it's very fibrotic, but that is, how do you call it, second line ESD, or it can be quite challenging.
All right. Now, Dr. Pouw, you have a patient with your with the low-grade dysplasia, and you decide on certain criteria that you go on to ablate. Are there any predictors for successful ablation? Is it success dependent on the patient, on the length of the esophagus, on the presence of the tortuous esophagus, on the expertise of the endoscopist? So can we predict a successful ablation, and what is a successful ablation what is the definition of successful ablation?
Yeah, interesting question. So maybe the definition of a successful ablation first, because I think that's easiest. So I think successful is once you've gotten rid of all the endoscopically visible Barrett's mucosa. And then we always take biopsies from the GE junction to see if there's no more intestinal metaplasia there. Once everything is gone, we say, well, there's complete eradication. So that's our technical definition, and we tell the patient everything is gone. And of course, we've looked at predictors to see which patients respond better to RFA treatment than others, because we know the rate of complete eradication is very high, but there are some patients that respond poorly or that need more time to heal. And I think most important moment in time where we can assess if a patient will respond or not is when they come back after their first RFA treatment. If they have responded well to the first treatment, the chances of getting everything removed get higher. And we know that patients who have esophagitis or very long Barrett's without any squamous islands within the Barrett segment generally have more reflux disease and may have a bit more complicated treatment course.
Okay, and the last question to you, Bas. So you have ablated the patient, you have ablated the low-grade dysplasia after 2 or 3 sessions, and you have completely ablated. So what about follow-up of this patient? Is it okay? Does he go away forever?
That's, of course, that would be the ideal world. And that's what we hoped when we started all the work on RFA, that we could ablate patients and send them home forever. But we didn't dare, and we also have some recurrences. So what we do, well, maybe we should divide this question into what to biopsy and what the intervals should be. What we do when we see there's an endoscopic disappearance of the Barrett's, and so an endoscopic complete eradication, then we perform biopsies of the neo-squamous junction just to see whether there is still intestinal metaplasia or dysplasia, and we rely on the endoscopic judgment of the treated Barrett's, so the squamous neoepithelium. And we only biopsy once. So the rest of the follow-up endoscopies we do on endoscopic, we trust our endoscopic eyes. In the past, we biopsied everything. We biopsied the neo-squamous columnar junction. We biopsied the treated Barrett's for 6-10 times, but that was not very effective. And only the random biopsies have a very, very, very low yield. But you really have to do a proper endoscopic examination, and if you see a visible lesion, then of course you should act on that. We are a little bit struggling in the intervals, and we are a little bit on the safe side now, being well, we still do the follow-up endoscopies every year for 5 years now, and then we expand the intervals to 3 to 5 years if patient is still not too old. But we think that that is a little bit too much. So we are now busy with well, all sort of predictor models, and Roos know more about that than I do, on our cohort of 1,000 patients to see what the optimal interval is. And it's probably less than once a year. But for now, we do it once a year.
Okay, thank you both. It was a great opportunity to have you in this webinar. So we gave a lot of information to attendees, and I'm very happy, judging from the questions that the majority of them were almost at the level of experts. And it was very nice to go very deep and in difficult aspects of managing Barrett's esophagus. For our attendees, the recording of this webinar will be posted on the e-learning section of the Eage website. There you can find also the past webinars, and you can check them out at our website. And it's time again to remind you of the benefits of individual members. Please go in our site, look at the individual membership, and look at the benefits of joining EAGE. You may get tutoring advices, you may get access to the quality check application, and you may get you may go to EAGE days at a reduced price. And the new opportunity is the registration, an offer from the EAGE, the package offer where a new individual member plus EAGE days 2021 registration can be made at a reduced price. So take advantage of all these things. And finally, all trips have an end. And it seems that my trip with the webinars has reached to the port of Ithaca. So for me, it will be my last webinar to moderate. However, webinars are not over. It was an idea of Thierry Ponson, and I thank him for giving me the opportunity to go on with this adventure. And then Claire Gay and Dave Inger stand by me, and we made this dream too, and we worked very hard on that under the pressure and the coaching of Hillary. And then Zilla appeared, and Zilla helped us in fundraising for this activity. And finally, we had a great boost from our president, Mario Diniz Ribeiro, and Gabriela Varga. And I would invite also now Gabriela and Dave to appear on the screen, because people would like to know which people are behind the scene and which are working so hard to deliver this this fantastic events. Dave is the mind of the activity. Gabriela is the heart of the activity, and of course other people who work with us. So dear colleagues, until our next meeting, au revoir, stay safe, and thank you for your commitment to EAGE webinars. So bye-bye.
Bye-bye.
Bye-bye. Thank you, Kostas.
Thank you, Kostas.
Thank you.